Right. I'm ready, sir. So, good morning. I'm here today to present an interesting case of back pain. This was one of the, if this was the first patient that I saw in this neurology rotation, it was something that is indelible to me, and I'll never forget it, I think. And this is why I wanted to share it with you. So, we have here a 59-year-old female with chronic back pain. She had the back pain because of a L2 to L4 fracture from an ATV accident 22 years ago. It was further complicated by another roof fall from 13 years ago on her T3, T4, which caused the fracture. And then again, 6 weeks ago, she had another T4 injury from moving furniture for her neighbor. So she said that her pain is chronic. It involves the base of the neck to her lower back. It's sharp on her upper back, dull on the lower back, and it radiates to both legs. She said that the intensity is the same. It's 8/10 every day, regardless of whether she takes Percocet or not. And she was also provided with gabapentin, but it made her shaky, so she wanted it to be discontinued. Her chronic back pain was also associated with headaches, poor sleep, and appetite. A little more about the background of this patient. She lives alone in the sixth floor apartment without an elevator, and she walks up and down more than 6 flights of stairs. She shops for her groceries unassisted. She drives herself to appointments. On the day that we saw her, she said she drove about 15 minutes by herself to the appointment. She wears an OTC back brace, and never did any modifications to her house or her car to accommodate for her disability. Her past medical history showed that she has controlled diabetes type 2. Her rheumatoid arthritis, however, is untreated because the patient did not like the treatment, and she was still looking for a rheumatologist at the time that we saw her. She has mild COPD, and a few years ago, she had a right knee replacement for her osteoarthritis. The patient does not drink alcohol. She continues to smoke 1.5 packs of cigarettes per day, and she was a former nurse before the accident happened. On physical exam, she refused PE as soon as she arrived at reception, and she also told us under no any circumstances that we should not touch her. It had to take some convincing to even just ask her if we could do reflexes. So she only wanted a medication refill and possible increase in her dose. When she came in, she walked in slowly, in pain, and she was bent forward. So we took her vital signs, they were normal. Her reflexes were normal too, except for the prosthetic right knee. And one thing I did notice that right after the visit, she was very quick to go out. These are her current medications that was provided by the clinic. She's on Percocet 7.5, Flexeril 10 milligrams, Xanax 1 milligrams, Ambien 10 milligrams. These were all prescribed to her from the clinic 4 months ago. So just to recap, here we have a 59-year-old former nurse who had 3 major back injuries and 1 knee replacement with chronic radiating back pain that is 8 out of 10 intensity daily with minimal pain relief with Percocet. She said she had poor sleep and appetite. However, she still drives, shops, and brings groceries upstairs to her sixth floor apartment without help. She refused PE and only wanted a medication refill. She walked in slowly and bent forward in pain, and she walked out very quickly after her visit. So she takes an opioid, a benzodiazepine, a muscle relaxant, and a hypnotic sleep aid every day. The assessment was chronic thoracolumbar pain secondary to fall and vehicular accident. And we added, perhaps she had an opioid use disorder. When we opened her chart, we were notified that she had exceeded her opioid and benzodiazepine threshold according to the Virginia Prescription Monitoring Program, or the VAPMP. It turns out that over the course of the last year, she had filled several prescriptions of oxycodone, alprazolam, zolpidem, and gabapentin from 6 different doctors and 4 different pharmacies. She used variations of her married and maiden name. She used different ID cards and paid all her transactions in cash. I was really quite surprised that there was so much information on the PMP alert about this patient. We discussed this with her gently. We just read the alert from the pages that we received. And then the patient insisted. She became a bit irritated that um, we were telling her about this, and she insisted it was identity theft and she was not an addict. Right after that, she took out a full bottle of Percocet containing 5 milligram tablets as proof. They contain blue round Percocet 5 milligram tablets. However, as noted in the list of current medications, her last prescription from the clinic was actually orange oval 7.5 milligram tablets of Percocet 4 months ago. So we don't know where she got the blue pills. The plan formulated by the clinic was to assist the patient with verifying the records with Virginia PMP, and no Percocet refills were given to her pending verification of her records. So I was really curious about what was happening with this patient. So I read the rest of her file, and it showed that over the course of the 4 years that she's been with the clinic, she has requested Percocet refills due to loss from car break-in. So she also said she fell from stairs. She was actually on a higher dose of Percocet 2 years ago. Like she was on 10 milligrams. And she has been repeatedly warned about the need to taper her dose because of the risk of overdose and respiratory failure. And it was not the first time on her visit that she showed a full bottle of pills as proof of non-addiction. Unfortunately, I could not find any record of her orthopedic findings or radiology reports. So it's something I think that we should obtain for the clinic, clarify everything and make sure we have everything on record. And I was wondering, how did the patient get here? How did the patient, this former nurse, a healthcare professional, one of our colleagues, reach this point in her life? She kept saying she can't be an addict because she knows the dangers of overdosing. And right now, the answer to this is she's been caught up in the opioid crisis that is enveloping the country. The opioid crisis in America brought her here. We have reached the point now when we can clearly view addiction as a disease instead of a lifestyle choice. And this disease is man-made, definitely. Whether intentionally or inadvertently, we physicians and other healthcare professionals that came before us made opioid addiction a complication of current pain treatment. So I had to look into what caused the US opioid crisis. And I found that there were three main factors. Historically, there was overprescribing, there was massive opioid exposure because it just, over the last 20, 30 years, opiates just flooded the market. And there were gaps in availability of other treatments, whether they were non-opioid or non-pharmacological. I highlighted historical overprescribing because at the heart of it, that's where we come in as physicians. It is something we can control, and the problem is exacerbated by the lack of coordination of patient care among healthcare providers. No one is overseeing pain management for these patients, especially for neurology patients who come to the clinic with really terrible pain. We need to remember, however, that when prescribed well and used as prescribed, opioids are valuable tools for effective pain management. The unintended consequences may occur from underprescribing, so you end up with patients with unmanaged pain, and overprescribing, which is the injudicious use of opioids. We need to remember that opioids make up just one tool in the pain management toolbox. We need to learn to manage pain without putting our vulnerable patients at risk for misuse or opioid use disorder. The goal is to keep our patients, our communities, and ourselves safe. So, how did the opioid crisis change pain management in the US? This is a very American crisis right now. Um, it has been in the news a lot, and I'm going to give you resources later on further reading for that. But because of the limitation of this presentation, um, I continue with other perspectives on how we are how we are dealing with the opioid crisis right now as healthcare professionals. So here is a DA schedule, a Drug Enforcement Administration schedule of drugs, highlighting which drugs that are available in the US market right now have the potential for abuse. So the ones that are uh, in bold and then black font in on this slide highlight those drugs that the patient that I saw is taking right now. So she's on a Schedule 2 drug, which is oxycodone, two Schedule 4 drugs, which is alprazolam and zolpidem, and a Schedule 5 drug, which is gabapentin. Well, in some states, gabapentin is not really a controlled substance, but in Virginia, it's considered a Schedule 5 drug. There are a few states that consider gabapentin as a controlled substance, and those are Alabama, Kentucky, Michigan, North Dakota, Tennessee, Virginia, and West Virginia. So whenever you do the residency here and practice here, you need to know what rules are applicable to the state where you're in. So many states have been trying to grapple with getting a handle on the opioid crisis. So they put up these prescription drug monitoring programs or PDMPs. These are reports on opioid prescriptions filled by each patient, and nearly all of them are available online 24/7. Right now, there are many operational PDMPs in the US, and in some states, prescribers are required to access them before they can even prescribe. The biggest help that we get from a PDMP is seeing how many doctors or healthcare professionals the patient goes to for these opioid prescriptions. Because multiple prescriptions from different providers is most predictive of opioid misuse. So, what are the benefits of prescription drug monitoring programs? They lower rates of prescription opioid related hospitalization and visits to the emergency department. They help reduce doctor shopping. They help reduce use of high doses and overprescribing. And they also identify drugs that increase overdose risk when they're mixed together or taken together. The problem is that these PDMPs are often underused, they're very time consuming, they may not have access to bordering state data. For example, just because I live in Virginia doesn't mean that I have access to uh, data from downstate, meaning North Carolina at the border. The patient might want to go to another doctor at the border to get a different kind of prescription. And another thing with these PDMPs is that there is lack of intuitivity in the formats. And many patients and healthcare providers are also thinking about privacy issues. As you saw a while ago, with the amount of information that was available to the patient, that was available about the patient, we even saw what kind of payment she made, what kind of IDs she used for getting the prescription, and when and what doctor, with which pharmacy she went to. And there are so many questions about the extent that that information can be used against the patient later on that is beyond uh, what is necessary to determine if she's taking uh, opioids or overusing opioids. So going back, what are we need to figure out, well, we do still need opioids. However, because of the opioid crisis, we need to figure out what the risks and benefits are of prescribing them. We every time we give an opioid to a patient, we put them at risk of a life-threatening respiratory depression or overdose. We don't know who's going to develop substance use disorder among the patients because we're not there yet. We don't have tests for that. And it could also inadvertently expose family or vulnerable children and pets if they find these opioids just lying around the house. Uh, we don't know, because patients sometimes shop for doctors. We don't know if the medications that they are taking from a different doctor is interacting with other substances that we're giving them. And in pregnant patients who are misusing opioids, their babies can have neonatal abstinence syndrome, where they receive addictive substances through the placenta during pregnancy, and then they end up having withdrawal symptoms during the first few days of their life. There's also the risk of that patients will have physiologic dependence and withdrawal. But on the other hand, opioids are amazing for pain relief, and they provide us with options to give to patients who have contraindications for non-opioid analgesics. Um, they relieve suffering, and they are amazing at improving function and quality of life. So this is the question that we usually get when faced with a patient like the one that just saw. The temptation is to ask what's wrong with this patient versus what happened to this patient. By choosing the question, we determine the approach that we use. These two questions lay bare our own biases with regards to addiction and substance use abuse. Because it was not long ago that addiction was considered a lifestyle choice and not a disease. However, thanks to that change in focus, we're now asking, okay, what's wrong? Instead of what's wrong with this patient, we're asking, what happened to this patient? What pushed this patient to go into substance use and abuse? And um, we now know that for every person that goes into that tries to get more opioids and abuses them, there is always a psychosocial component that we hardly ever ask. And in retrospect, had I had I had more time with the patient, I would have wanted to know what social issues or personal issues or psychosocial issues that she had but unfortunately I didn't ask that. That's something I regret. We need to, for each of these patients, we need to delve more into the background that contributed to their substance abuse. Um, Initially, when I was interviewing the patient, I had to be careful because the only way I could get to the truth is by building trust and rapport. I could not seem to be interrogating her, even if, as the way she relayed her history, more and more things did not make sense. I mean, how can you have 8/10 pain and still drive yourself to the grocery store and do your groceries, drive back and walk up with your groceries up at least 6 flights of stairs? If it's a big condominium, that's 12 flights of stairs with no help, without modification. I mean, I even asked the patient, isn't it great right now that we can just have things delivered to us? And she said, no, no, I do everything for myself. She even said, I'm tougher than you think. But is that being tough mean she doesn't really need the medication? So eventually, the inconsistencies in her history clashed with the incontrovertible evidence presented by the PMP report. And at the end of that, she just deny as much as she wanted. She could deny as much as she wanted to, but the evidence was there. However, we still need to remember that the way we ask the questions matter. Words that we use matter. There's this really nice quote from Don Corey's where he said, if you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And now, because of that, we have to change our perspective in the language and the terms that we use when dealing with these patients. Instead of saying addiction now, we say substance use disorder. Instead of saying or writing in our history that patient is displaying this drug-seeking behavior, we need to say she is not using the medication as prescribed. Instead of calling the patient an addict or a user, the way that she was so affronted when we confronted her with the information from the PMP. And she kept insisting, no, no, I'm not an addict. Instead of calling her an addict or a user, we could just say, this is a person with substance use disorder. If we don't say anymore, oh, she failed a drug test, we can just say she tested positive on a drug test. It's not abuse or habit, it's misuse. Here we are with the question that really struck me on the day that we saw her. How how far do we go with displaying compassion and balancing it with the necessary vigilance we have to do to not only protect the patient and protect ourselves too, because it's your license at stake. Um, is especially when approaching a patient like that, compassion can be difficult when we are tasked to prevent the overprescribing that caused the opioid crisis in the first place. This is a question that we need to answer in the moment when we encounter patients who ask for these drugs. I still wonder today, did we do enough for this patient? Is there anything more that we need to do? Is there anything we could modify in our approach? Because at the end of the day, we don't want to vilify these patients because addiction is a disease and it's a complication of the treatment that we prescribe. So, as young physicians, we need to know about this early in our careers, especially those who are going into neurology, because we need to avoid repeating the mistakes of those that came before us. I know that this presentation does not go deep enough because of the limited time I have to discuss this topic. I am going to give you in the next slide some of the resources that you could look at to make yourself more familiar with it. But I hope that by showing you this case, I can give you, my colleagues, especially my fellow IMGs, an idea of what it is like uh, to prepare yourself for patients right smack in the opioid crisis here in America. So, yeah, here are the resources I was talking about. There are so many documentaries, books, and TV series right now that were uh, made in the last 10 years about this issue. And just a few months ago in the news, I read about one of the leading uh, pharma companies that got into trouble because of really pushing opioid use and abuse in America, which is Purdue Pharma. They already did plead guilty, but they're trying to get away with not paying anything or going to jail. Fortunately for us, the Supreme Court has blocked that sweetheart deal that they tried to get, and I hope that those patients who lost their lives and those families that were affected can get some justice. But let's not think that the responsibility is just with big pharma. Um, Even the drug companies, even the drugstores were involved. The distribution of the drugs were really on them. However, again, it starts with us. So I hope that we will be better at managing pain for patients without putting them in a more difficult situation than when they started. Thank you.